Hi, everyone. I'm Gale Bataille, and I actually have been unbelievably fortunate in the last 6 or so years to work extensively with the California Institute on various kinds of approaches to integrating care, including the learning collaboratives that Sandra mentioned. And I've also had the opportunity to work with the Integrated Behavioral Health Project. So I get the best of both worlds in terms of working on issues of integrated care. So this next part of our summit is a chance for you to kind of soak up some ideas, and we will have plenty of time at the end for some discussion because we really do want to hear from you and give you an opportunity to ask whatever you want of our panelists. And so in this summit, we really are focused on understanding California's challenges and working with each other to develop practical, doable solutions across sectors to improve integration and coordination of care. But to develop effective integration strategies, we have to focus on not only the nitty-gritty of how to get through and come up with some solutions to the challenges that we face, today and over the next year or two, but we also need to think about the future as we craft those solutions. And we very much want to learn from the experiences and lessons learned from other states. So I'm really very pleased to be able to introduce, and I'm going to introduce each speaker briefly. They will give a presentation. If you can hold your questions, we do have mics and we do have people who will come out to you. So after each presentation, if you will ask basically just clarifying questions if there's something you didn't understand, and then we'll reserve time at the end to have a wide open discussion. So I want to let the speakers get through their presentations. So first, I'm really pleased to introduce Dr. Christina Milano. She's a family physician, medical educator, clinical leader at Oregon Health Science University. And in addition to directly caring for patients, she is very committed to transforming the vision of the medical home. And I'm not going to go, her bio is in your packet, but I think some of the things that are really interesting are that she has, in the last couple of years, been the project lead for the Richmond Engagement and Community Health Team, which is a Center for Medicare CMMI Services innovation grant that is looking at health utilization. And she's also been a champion for the Primary Care Renewal Project at OHSU. And so she's really worked a whole lot with transformation at the ground level and also at the kind of thought policy level. And I would say that that's true about both of our speakers. So Christina will speak first. Harvey Rosenthal is going to do more of a self-introduction, but I'm going to say a couple of words. Harvey has many years of experience, over 38 years, he says, working to promote public mental health services and policies that advance recovery, rehabilitation, rights, and community inclusion of people with lived experience and with psychiatric diagnoses and conditions. He has been for over 20 years now, I guess, the executive director of the New York Association of Psychiatric Rehabilitation Services, which is a statewide peer-led partnership of consumers and providers dedicated to improving services. And I'm not going to go into all the detail. He will probably say more. But one of the areas in which I think Harvey brings some real expertise is he's been an active member of New York's Medicaid redesign and Olmstead planning bodies, and they're doing some really interesting work in New York. So we wanted to go out and find a couple of state experiences. So we went to both ends of California, both ends of the country, California is not the world, we know that. And really brought these two folks here because we think that there's some really interesting experiences, especially around system transformation at the ground level as well as at the policy level that they can speak to.
Thanks so much for that introduction. It's wonderful to be here. I would call myself a visitor from another state, but I'm actually a born and raised San Franciscan, did my medical school training at UCSF. So think of me more as one of you who's gone off to do a little investigating because I hope to come back one day soon and reintegrate. I'm thrilled to talk about what's happening in Oregon and interested to hear your questions. I say that with the caveat that whenever I am at a health policy conference or at a meeting and somebody brings up Canada and how everything is so great in Canada, I feel compelled to remind whoever's speaking that Canada has the population the size of California and that it's very hard in the United States that's so enormous to do what they're doing in Canada, and it's so easy for them because they have so few people. So I liken that to me coming here and talking to you about Oregon, because obviously Oregon is a much smaller state than California. I don't know my numbers exactly, so I hope you'll know that, and I appreciate the fact that in many respects, doing this work just gets easier with the smaller number of people that you're working with. So I was sitting at this table with these lovely ladies over here hearing about some of the extraordinary complication in the California system, and largely, I'm sure, because of the size alone could explain much of that complication. So I am going to be talking both about some larger scale things in Oregon and then a smaller on-the-ground activity that's happening at my clinic where I'm the interim medical director, which is an FQHC in Southeast Portland. But just to give you some background as to what's happening in Oregon, I'm well aware that most of the news that you hear about Oregon is that our website is broken. And it's that sort of funny thing, right? Story 1, 2, 3, 4, and 5 about Oregon is that the website doesn't work. But actually, there's a lot of really fantastic stuff happening. And I don't intend this to be a political speech, but I did put a picture of our fine governor, Dr. Kitzhaber, up there, who has been a strong leader in a lot of this work. So 2011 was a sort of find yourself moment for Oregon, and really a crisis time when we had a huge deficit, so a $3.5 billion state deficit, and really most of that was Medicaid attributable, not for mismanagement of Medicaid. It was a time when many new members had enrolled. We'd lost a significant amount of federal funding at that time, and we took a long look at the fact that the state's general revenue had a rate of inflation or rate of increase of 4%, while Medicaid expenditures were increasing at a rate of 5.4%. So that essentially created this completely untenable, unsustainable situation. So health leaders in the state, led by Governor Kitzhaber, essentially assembled and proposed a plan that was taken to Washington, and they cut a deal with the feds. They said, if you'll give us $1.9 billion and 3 years off the hook, we are going to completely reorganize how we're delivering care in the public sector, with the great hope that we'll create a sustainable model that the private sector will be interested in modeling. And in fact, the plan will be to work with Medicaid patients first and then enroll all of the public employees in the CCO model, and then eventually, again, hopeful that the private sector would follow. And the feds seemed to think that was a great idea. The promise included a promise that rate of inflation of Medicaid expenditures would come down to 3.4% over the 3 years. So we are in the midst of this transformation right now. 15 coordinated care organizations were formed throughout the state. I'll define the CCOs. Those are essentially geographically co-located health systems coming together to receive Medicaid payments in a capitated, or what we call the alternative payment methodology model. So getting away from a fee-for-service model and putting the risk of being attributed patients onto the health systems themselves, and getting that middleman, which in Oregon is either Care Oregon or Family Care, the two major entities that manage the Medicaid funding, out of the picture. So 15 CCOs were formed. The promise was made to lower the inflation rate, and then essentially 30 quality measures were put on the line with a promise to return on or improve on with some incentive payment attached to that. We're in the very midst of this. We're about a year and a half into the experiment, as we call it. So far, we've seen some great returns. We've seen about an 8% reduction in ER utilization. Primary care visits have gone up by about 30%. We have about 40% of our CCO clinics in a PCPCH confirmed model. We have a reduced readmission rate for CHF admits. So some of the early numbers seem to be promising in terms of the rate of the inflation. We aren't seeing that change yet, but again, that's something that will take much more time to look back at. So that's sort of the general climate of where Oregon is at right now. The largest of the CCOs to form is the Tri-County CCO. There's one major metropolitan center in Oregon, as I'm sure you all know, which is the Portland metro area and made up of 3 counties. And the CCO that formed there has really been sort of the flagship CCO. We have about a third of the state's Medicaid members as a part of that CCO. And the leadership that when I mentioned some of the health leaders involved in going to the feds in 2011, those were the folks who were leading Care Oregon at the time. David Labby, he's now the medical director of Health Share of Oregon. They were the ones to come together and really rally us to this place where we are now. And so it's a really exciting place to be and an exciting CCO to be working with. What's really interesting, I think, hopefully to you, is that it's not only physical health entities that are part of the CCO, so that all 3 of the county's mental health branches are part of the CCO. The governing body of the CCO includes executives and leaders from all of the entities that make up the CCO. There is a patient advisory component to it as well, a community accountability component. And essentially, the goals are very clearly articulated. The primary goal of the HealthShare CCO is to have integrated mental, physical, addiction, and dental health. And with that alternative payment methodology that I was referencing, so a non-fee-for-service based, so essentially a lump sum approach to payment, that would include the mental and dental and addictions as well. We're in a transformative time, so it's not exactly happening that way as I'm describing it. That is the goal. And part of the reason why it's not happening immediately now is that you heard me mention that all of these CCOs, all of these health systems involve the shifting of the risk from the middleman, the Care Oregon or the healthy families, to actually Oregon Health Sciences University or Multnomah County Mental Health. So there's a process underway to make sure that these organizations can absorb that risk as they become the recipients of the funding directly from the state and the feds. There are 2 main activities that the Health Share of Oregon CCO is leveraging or hedging its bets on, and one of those is PC-PCH transformation among the clinics that make up the primary clinics in the CCO, and the other is using some novel approaches to manage high acuity and the high utilization, higher cost members. So the PC-PCH part is what we think of as sort of the easy part, and I mean that somewhat facetiously, but this is an area that we've been working in Oregon for quite some time. So in 2006, several healthcare leaders went on a pilgrimage up to Anchorage to the Native American Health Center up there, really witnessed an incredible thing that was happening in terms of integrated behavioral health, improved continuity, really patient-centered care, and there was a funding stream created in Oregon for clinics to really transform themselves towards that model. It is now actually a mandate of the state, so we have essentially written it into law that if you are a primary care clinic in Oregon and you wish to receive Medicaid funding, that you need to meet criteria and essentially be called a Tier 1, 2, or 3 patient-centered primary care home, and that process has been underway for about a year. There are 6 components to that, one of which is integrated behavioral health. I can describe how that looks at my clinic, at Richmond Clinic. We are a federally qualified health center. We have about 12,000 patients. We have 25 medical providers and 12 family medicine residents. And for those, that works out to be at about 20 FTE of physical health providers. To match that, we have 3 full-time social workers who are co-located with our teams. Our social workers are empaneled and engage in warm handoffs. Every patient who arrives at the clinic gets a mental health screening and a substance use and alcohol use screening tool. We have a psychiatric nurse practitioner who is a full-time provider and has a room and a template exactly like any other provider in the clinic and sees patients all day long doing assessments and providing consultation on medications. And then just a number of other more auxiliary type services that we provide that we put under the sort of the umbrella of behavioral health. So those elements of the PC-PCH and that aspect of integrated behavioral health, we feel like we understand. We're just trying to figure out more and more how to make that sustainable. We have some funding that comes directly from the payer in terms of a per member per month payment that's specifically just earmarked for behavioral health. And then we've also started using some of this alternative payment money to underwrite those services. The harder part of the equation, and the piece that I think has been really capturing our attention, is this second piece, which is really addressing the higher utilization and the higher cost members. So if we look at how this plays out for Oregon, I'm sorry this isn't particularly clear. So these are Care Oregon members in 2011. The top box represents the number of members, and then that small red square in the top box applies to the smaller box in terms of the cost. So a quarter of the members represent 89% of the costs in 2011 for our Care Oregon members. And if we look closely at what the diagnoses are associated with those particular individuals who had such high cost utilization, top 4 diagnoses, mental illness, chemical dependency, ADD, and post-traumatic stress disorder come out as a majority of the diagnoses for those folks. In terms of where the costs are coming from, predominantly hospitalization admits and ER utilization. So that's what the data looked like for those individuals in 2011. When we mapped those patients out in Portland, Oregon, and looked at them in terms of where they were, we learned something sort of in a geographical way that made a lot of sense, which is just that the higher density of patients completely and totally overrides the zip codes where you have higher incidences of poverty. When we actually looked at those patients just at Richmond Clinic, the proportion in terms of number of members, percentage of members, and what they were costing was a little bit less imbalanced as the graphic I just showed you. So about 14% of our members represented 50% of cost. So this was true for all of the clinics, essentially, who were part of the newly formed CCO, and we were asking ourselves, what are we going to do about these higher cost patients? You'll notice that I've been really cautious about not using the word hotspotter. Has anyone in the room read the Atul Gawande article about hotspots? Great, super. So an article came out in the New Yorker about 3 years ago, a really well-written article about some work that's being done by Jeff Brenner in New Jersey. And the article was titled Hotspots, and it was referring to zip codes where there were high numbers of patients who were suffering from medical conditions related to their indigent status. And somehow, suddenly, all of these patients all over the country are being called hotspotters. And so we've really tried to get away from that, and I'd encourage you to do so as well. So we essentially say patients with modifiable high utilization, but really trying not to call them hotspotters. So take that thought. If you take one thought from my talk, there it is. So the members of the CCO got together and essentially collaborated to write a grant proposal to the Center for Medicare and Medicaid Innovations, specifically addressing high utilization, modifiable high utilization, and trying to take some novel approaches to addressing that above and beyond what we can offer at baseline as a PCPCH. So really recognizing that the PCPCH does a lot for a lot of people, but this particular subset needs something much more. So the grant was funded. It's a 3-year grant. It's funding 5 interventions. The 5 interventions span all of the realms where these patients are actively touching the system. So there's an intervention at the level of the actual ambulance rigs. There's an intervention at the EDs. There's an intervention in the hospital, interventions with specialists, interventions in the primary care clinic. It's all the points of entry. I would encourage you to check out the website. This is it, just to get sort of a better opportunity to read more about the details of the 5 interventions. I'm specifically going to talk about the health resilient specialists at our clinic, but this is a great place to check it out. The interventions are parsed out in terms of level 1 and level 2 based on the acuity of the patient. So one of those interventions is the Health Resiliency Program. And the concept was that we needed to maybe be looking outside the bounds of traditional medical training or traditional mental health training to identify individuals who might be able to partner with patients in a way that we hadn't been doing before in the context of our medical home. So a cadre of pilot health resilient specialists were hired. These are individuals who have very unique backgrounds in patient engagement. So Lisa, the woman on the left, has a background in the public school system. She spent years working with homeless families to advocate for getting their kids into school. The woman on the right has a background leading what are called community clubhouses in Portland. Again, neither of them with medical training. These are individuals who we essentially said, we know who our patients are who have higher utilization, so why don't you just meet the patient, talk with them, see if they're interested in working with you, and then we gave them a lot of leeway and autonomy to figure out what it was that was going to support that patient. Was it going to their house frequently? Was it meeting them for coffee? Was it just being someone they could call because the patient felt more comfortable calling the health resilience specialist instead of the clinic? Would it be going to specialty appointments with them as if a surrogate family just walked in the room and said, hey, why don't I go to the cardiologist with you and I'll take a listen and then we'll talk about it after? So a wide variety of potential interventions there. Because we had these two new individuals working in our clinic, we felt like we really wanted to surround them with some additional support, and we saw some gaps in what they could do and what else we felt these patients needed. So at my clinic, we created actually a whole team of folks, and this is what the team is made up of. We have our health resilience specialists. We have a social worker. This social worker does not participate in the warm handoffs I was describing earlier. This social worker has a unique role. We call him our transitions social worker, and he essentially, we have an individual, the care coordinator, who's doing surveillance of who is in the hospital, where that patient is, if they're in the hospital, if they're approaching discharge. She's checking that information every day. Our transitions social worker then contacts the case managers in the hospital setting and says, what is the warm handoff you need to give me that's of a social work context? So at my clinic, we have a relationship with OHSU such that as a physician at Richmond Clinic, if my patients go into OHSU hospital, then I take care of them in the hospital. So we have a really clear understanding of the continuity of care between the outpatient and inpatient world in a biomedical setting or a biomedical way. What this social worker does is he's doing that same thing. He's mirroring what all the doctors are doing from a social worker perspective. So he essentially follows the patients in and he follows them out and he engages with them for 30 days afterward if they have social work type needs. We have a nurse on the team. The nurse makes phone calls with patients in that 30 days after they get discharged. And we actually also have a pharmacist on the team who helps with med reconciliation and for those patients who are engaged with our health resilience specialist, really sorting out some of those really complicated med packages. So this is the REACH team. I've just talked a little bit more about those folks. We have a devoted time of an hour and a half every week where we get together, myself included, and we essentially run the list of who's currently in the hospital from our clinic, and then also any of the patients who are currently engaged with the health resilience specialist who might need some feedback or commentary from the pharmacist or myself as the clinical lead on the project or from the social worker. So it's a regular activity. We have a regular list of these patients that's maintained by our care coordinator and some really enhanced information about them when we run that list. We've learned some really interesting things. Some may seem obvious to you, some have been novel for us. We definitely see as a point of change or potential modification the pharmacy issue. And we have found on average these patients have 14 plus medications on their list being prescribed by 5 or more providers with an average of 2 mental health providers. So we have found that polypharmacy and patients' understanding of their medications is a huge area where we could have effectiveness. We were amazed at the number of patients who clearly were in need of a consultation about what palliative care could do for them or potentially that hospice could do for them. And that has been an incredible point of action. And because of our understanding around that, actually the CCO is planning to open a new hospice care service in Portland. We have had a paradigm shift in the clinic where suddenly all of the providers are like, oh, the REACH team, oh, is my patient in the hospital? I got to get him out of the hospital. There's sort of this new awareness about why patients go to the hospital, what's driving them to go to the ER, what could we be doing better? Maybe we should do a referral to the psych nurse practitioner. So a real awareness in the clinic around utilization issues. We have much greater improved intra-system communication between the hospital, ourselves, the community pharmacies, just lots of conversation going on that hasn't been happening before. And this is one of my favorite, the texting one. We have so many patients whose phones have been turned off or who will not answer their phone because they know they're about to run out of minutes, but they text with our health resilience specialist and they text with our social worker. And so we don't, as a clinic, engage in texting. We haven't really figured out, as this enormous clinic, how to do that. But for these individuals, that has been a great pathway for communication. Some of the areas where we're running against a wall, we still are having issues when at the end of the day, we cannot figure out how to connect the patient with adequate substance use treatment. And that's an area where the CCO has a lot of work to do. We have 3 providers in our clinic who are Suboxone providers. Suboxone is a treatment for opiate dependence and can be prescribed by a primary care provider. And we are trying to get every provider in the clinic certified to be a Suboxone prescriber. We have struggled just really thinking about the fact that we have all of this work going on in the PCPCH context. So the PCPCH is about calling patients when their PAPs are due or when they need to be on a statin because they have diabetes. Those kinds of activities have proven to be distracting for these particular patients. And so we're trying to think about how do we excuse these patients from sort of the usual requirements of the primary care medical home and just give ourselves the permission to take care of them in a context that will work for them without them getting strange phone calls in the middle of a Wednesday that they need to come in for a pap smear. And then last but not least, homelessness continues to be a challenge for us. Despite all of the engagement, patients who are living on the street, under a freeway, we have not had as much success with. I'm pleased to show you some early data. Essentially just looking, we've worked with about 600 patients at Richmond Clinic so far, and in both ED utilization and hospital inpatient stays, we're seeing favorable trends. We know that there's some amount of this that is regression to the mean. We think about somewhere in the ballpark of 15 to 20% is a typical reduction for regression to the mean, and we're seeing a trend of about 30% reduction. So we are attributing about 10% to our actual intervention so far. So that's what I wanted to share.
I have a question about the role of the physician who may leave the clinic to visit the patient in the hospital. And I may have misunderstood. I certainly understand the role of the social worker and the health resistance worker. But if the physician is also visiting, what is the role distinction between the hospitalist and the physician?
I think I may have not described that perfectly. So as the physician lead on the team, I don't actually go in and see the patient. What I was saying is that the faculty physicians in my clinic, we are responsible for all Richmond patients, and we have shifts of a week. We become the hospitalists. So we become the hospitalists on a rotating schedule for all of our patients at my clinic. So I might be the physician in the hospital. It might be my week to be on, but in my role on the REACH team, I am not following patients, and I'm just consulting the team. And the whomever is the hospitalist of the week works with the patients who are in the hospital. Exactly. There's no double. And similarly, I've been sometimes thought like, well, maybe all the REACH patients should become my panel, but we haven't gone that way. We've really honored the continuity they have with their PCPs, and I don't inherit them.
Quick question. How would you compare Oregon's CCOs with what the ACA defines as accountable care organizations?
So accountability is is a key element to all of the CCOs. It's not as if there isn't that aspect to it. And there are, as I mentioned, there are these 30 measures, and actually if not all of the CCOs have to perform collectively on those measures to a certain level, or the state as a whole will not get the incentive pay. So it just is the fact that it is a collective activity or endeavor rather than being a singular endeavor. And some of the health systems, originally there were 16 CCOs. Now there are 15 because a few pulled out and said they wanted to be ACOs independently, and so we're seeing that happen. Yeah.
You said that you are working towards providers to become certified to prescribe Suboxone.
Oh, yeah.
Not methadone, not Vivitrol, and not counseling around that, because I'd imagine you wouldn't want to dispense without some type of counseling occurring at the same time.
Great. So Suboxone is the only approved medical therapy for addiction that can be provided in a primary care setting that is not an addiction treatment setting. So I can prescribe methadone for pain, but the FDA says I can't prescribe it to treat heroin addiction. I can prescribe Suboxone in the context of my clinical environment. So it's the only one of the opiate treatments that can be prescribed in the context of primary care. And then we have group Suboxone visits to support the process as well. So we have a counseling element to it, and we have an addictions credentialed social worker who does DBT and seeking safety groups for all of our patients, actually.
Hi, everybody. I bring you greetings from New York, and I bring you the flu as well, so be careful. So if I cough or I need to drink water, you'll understand why. And I have a lot of slides, and so I'm going to sort of shorten this a little bit, and you'll get these online, I think, when I'm done. NIAPRS is as we heard before, a peer-led sort of coalition. We're an odd sort of duck. On a given day, we may look like Campro, and another day we'll look like Casra. So we're an odd sort of coalition of peers and providers working together to promote recovery, rehabilitation, rights, and community integration. NIAPRS.org, there's a lot of information there that will elaborate on what I'm going to talk about. And just really quickly, NIAPRS has been involved, really just tried to be a change agent for 21 years in New York, trying to push the envelope through advocacy, through training, recovery training, to a whole host of providers, employment and economic self-sufficiency campaigns, initiatives related to cultural competence, and something we're very proud of, a number of peer innovations, including creating the peer bridger model back in 1993. For us, I think, as Patrick said, this is an unusual time of great change, and it's all happening at once. Well, I love that, because change has been so slow. As I said, we've been doing this for 21 years, and recovery in many instances in name only, in pockets throughout the state, but not the norm, not the default. And so for me, there's a number of pressures that the stars are aligned for a perfect storm for recovery. We can't afford chronic care. Can't afford saying to people, you're always going to be in services, you're always going to relapse and be readmitted. Our budget director and our Medicaid director want people to get well. Those are new allies for us. They've not been allies. We have the Affordable Care Act, which in New York is called Medicaid Redesign. And I am on that team. And that team is interesting because it brought together all the entities that usually resist change. There's also a good deal of recovery-focused education and training. As you heard before, because people with behavioral health conditions, we spend so much money on them, so we became in the focus. We used to be really sort of on the margins, sort of an afterthought for Medicaid policy and budget policy, but because there's lots of savings that need to be made, we're in the focus. Then, of course, you have the Olmstead and the heightening of the recovery movements. So for me, it's all come together rather well. So here's our slide in New York about the cost. This is what really kicks it all off. We have a $54 billion Medicaid program, 5 million beneficiaries, 20% or a million use 80% of the dollars, primarily in hospital emergency room and many medications and a lifetime in services. Over 40% of that group have behavioral health conditions. So we become more important. Something needs to be done and to be changed. New York is number one in the nation. We like being number one, but not for this one. Most readmissions. Most people that are going back into hospital between 5 and 30 days. And of that group, 70% have behavioral health conditions. And as you might guess, 3/5 of the time, it's for medical reasons. And for all this money being spent, we have a $54 billion Medicaid program, a $7 billion behavioral health program. People are dying early. People are, disproportionately represented on the streets, in jails and prisons, and are vastly underemployed. So a lot of money being spent, not a lot of outcome. So I mentioned the redesign team. These are the various work groups that were formed. One of them is behavioral health, and I was on that group as well. We have in New York, the health department really manages our Medicaid, and our Medicaid managed care programs are dealing primarily with medical services and pharmacy. We have a separate mental health agency and an addiction agency, and they're slowly merging. And the services that you see there are the fee-for-service Medicaid services. Now we have a rehab model, ACT teams, partial hospital clinic, opioid services, all of them in silos, all of them on a fee-for-service basis. We do have some array of state aid, but all of it is segregated, siloed, and under-coordinated. So here's our principles of Medicaid redesign. we're going to a carve-in. We're taking all of this fee-for-service dollars and giving it over to the health plans. A big job for the health plans, who in many instances have been working with people with lower needs and doing it through some form of telephonic sort of coordination. They really have a big learning curve. They also are going to get a lot of money, a capitation rate that will increase by $2,600 a month. So, going to make a lot more money, a lot more work. There's supposed to be a universal access to primary care. We'll talk about health homes. And there's a real focus. Our Medicaid director is interested in peer support. He's interested in housing and employment. We were worried when we were going to sort of slowly merge with the health department. It would be very illness-based and medical-based. He gets that the way to help people stay out of hospital is housing, employment, peer support, things like that. So he's our biggest ally. I never would have expected that. Here is the gist of our system. I don't know if you can, how well you can see it, but the state agencies, primarily the Medicaid agency and advised by the mental health and addiction agencies, are turning over the benefit to the health plans. Health plans that are going to work with people with more serious needs are going to meet a formulation called HARPs, Health and Recovery Plans. That's the one that's going to get a much higher capitation, much higher bar. The state is setting a very high bar for those health plans. In turn, the health plans are going to work through health home networks of providers, a full integration, mental health, addiction, social service, medical, hospital, and a variety of providers. And we're supposed to do our work in health home networks and in turn form a treatment plan that is approved by the health plans and ultimately produces the outcomes that the state is looking for. So the HARP is what we're calling it in New York. And like you're hearing in Oregon, a lot of what I'm going to tell you is a few months away. A lot of it is not up yet. Health homes are up, but the HARP is not up. And it's about to come up in a few months, really, in New York City and then otherwise upstate. Health plans are able to manage this and take on this benefit and these folks and this kind of care, but only if they meet high standards. If they're not able to do it alone, they're going to have to subcontract with the behavioral health organization, Value Options, Beacon, Magellan, Optum Health, and things like that. The capitation, as I said, the carve-in is $2,600 a month. I'm going to move ahead here and just, you can imagine that these are folks with higher needs and there's a broad element of criteria. If you're on SSI, if you've been on ACT, if you've been in the hospital the last 3 years of a magnitude of 30 days, if you've been in a state psych center, if you're on an outpatient commitment order, and a variety of other criteria, you're going to be in a HARP. And just while I'm on the topic, you're going to get, it's passive enrollment. So you're going to, if you're in a medical health plan now, more than likely, if you don't take action, you're going to be in that health plan's HARP. So this is the big slide for me. I'm an advocate for recovery. And unfortunately, most of the money's been going to, in my judgment, illness. Hospitals, emergency rooms, what have you. But I got this new ally, the Medicaid director. And so the Medicaid director, with our advocacy, we've been advocating for this in New York for 3-4 years. There is an option from CMS called the 1959 Home and Community-Based Services option. It is the most flexible form of Medicaid, and it allows Medicaid to pay for things that currently are only payable in state aid and live on the margins of the system. But now they'll be in the mainstream. The HARP, the health plan, is not only supposed to offer all the fee-for-service mental health and addiction services, but they're supposed to extend into things like rehabilitation, crisis intervention and crisis respite, family support, peer support, self-directed services, my favorite. The most transformative thing is giving service dollars to people themselves, not making them access a program. In fact, one of the first models of that was in Oregon, Empowerment Exchange, where they gave money to people on an individual basis and they purchased the things they really need. So they weren't in programs getting ready to get jobs, but they were being given the money to buy a job coach, to get a suit of clothes, to fix their car, to have an internet connection, right? The most transformative thing. And employment, which has been a real debate. In New York, we were debating whether Medicaid could go beyond illness management. 4 or 5 years later, it's going to pay for peer support, transportation, rehabilitation. So, and any health plan that wants to do the HARP has to provide all those. And so the exciting thing on the health plan, sometimes look at me and they say, Not only do we have to provide ACT, which we don't know what it is, or rehabilitation, we're on the hook for whether people get jobs. The HEDIS measures in New York have been, perhaps like they were here, very medical. Did you get to the doctor in 7 days from discharge? Are you taking medicine in 30 days? This sort of thing. But we've been working on the behavioral health work group. We suggested a number of outcomes that we consider to be more to the point of recovery. So their health plans will be measured and their provider networks based on how many people have had a movement in their vocational life, including a job. How many people have stable housing where they didn't before? How many people have access to peer support? So peer support is not only a required benefit that the plans have to pay for, but they'll be judged on whether people got it. The plans have to show that people are in the community more and not going back to the hospital, that they're staying out of jails and prisons, and that we're also engaging minorities who are the most underserved. And this is really exciting in that we're generating already hundreds of millions of dollars of savings. Even before the HARP is coming, people are getting, got to keep people out of hospital and emergency room, have to form new approaches, relapse prevention, crisis respite and diversion. So already generating lots of savings, but the good news is we've required that the money stay in the system. So behavioral health is separately tracked too, so it doesn't migrate into healthcare or into roads and bridges. And there are going to be incentives for wellness outcomes and the use of peer services. Peer services required benefit, part of the outcome measure, and they get a portion of the reinvestment. We've worked very hard on that. And plans even have to be selected by showing they're contracting with peer support services. So we were approached a year ago by the biggest health plan in New York City, and we're now doing a peer bridger program for them. Part of it is they want to qualify to do the HARP. Part of it is great for us because they are the hospitals and they get us in early. People's admissions in New York and Medicaid managed care are 7 days, 8 days, 9 days. That's the time to really make the relationship. They get us in there. Health homes, as I said before, I think you heard a little bit about it. Everybody in a health home gets a dedicated care manager. We in New York took all the casework, the case managers from the Office of Mental Health and the Addiction Agency and reconverted them into care managers. The care manager is supposed to work with the person and the system to produce one plan that is shared electronically on a regular basis. And of course, as you heard before, is supposed to guard against polypharmacy and segregation and lack of coordination. Health plans are accountable for reducing, everything in New York is accountable for reducing avoidable readmissions. Health homes, HARPs, and something you'll hear about in a minute called DISRIP. And they're expected to do 24/7 response. So you're not able to punt it over to the emergency room. When someone has a relapse or they're in the emergency room, the phone is supposed to go off for the health home. Somebody's supposed to go out and be involved. Health home leaders get a separate monthly rate. The network providers are being paid right now in fee-for-service and ultimately in managed care. And they'll eventually subsume that. But health home care management is a separate rate, pays for the care managers, the electronic healthcare records, and administrative costs. Here's an example of a health home in New York. You see a number of health plans. The hospital, this is in Buffalo area. All the behavioral health providers in that area, all the medical providers, housing providers, and miscellaneous. Another exciting thing is health homes can reprogram their care management dollars to buy peer services. You heard about, I think, health resiliency. Well, what we've been developing is peer wellness coaches, which is really, we took our peer bridgers and had them trained by Peggy Swarbrick in the 8 dimensions of wellness and health literacy, sort of training and what have you. We try hard not to be doing the casework and the transportation. We don't believe that that's the best use of peer support. We're about the relationship, persistence, outreach and engagement, the promotion of hope, and we stay with people quite a while. And the thing with our health home groups are these folks are by definition have multiple conditions, have housing instability, the addresses are not accurate, we're on the street. You know, when I started working in the field, I was written up for being out of the office too much. And I was, in the beginning years, out of the closet. Now, I can be out of the closet, and I'm supposed to be out of my office and on the streets working with people. That's the way it should be. We did this thing with Optum Health in the precursor of the health home called the Chronic Illness Demonstration Program, sort of a bad name. But we made this up with Optum. And eventually we went up with a triangle of a care manager and a nurse and a peer wellness coach. And so the nurse really had the highest, like 1 on 100, probably even higher, the ratio. The care manager did a lot of the coordination and linkage. Our peer wellness coaches were fabulous, honestly, in doing a fabulous job. Here's an example. We had a person in Queens, 40-year-old man. He was diagnosed with a bipolar condition. He had major issues with alcohol and drugs, and he had renal problems because of the drugs. He had been, prior to our engagement with us, had been in a detox for 7 times, and his Medicaid utilization was $52,000 for that year. We engaged the peer wellness coach. She went to the home again and again and again. She made a relationship with the mother. She couldn't find him why he was using all the time. She finally, when he was next admitted to a detox, she went and engaged him. She eventually helped him get into a rehab. She picked him up the day he left the rehab. She took him to her 12-step meeting that night, and she stayed with him. She called him every day, visited him and supported him. And the next year he had 1 detox, and his Medicaid went down from $52,000 to $20,000. This single slide has gotten us 3 contracts with managed care plans. When you pull that out, they're all ears, you know? And for good reason, because recovery is good business. It's the right thing to do, but it saves money, it helps people get well, helps people not be chronic patients, but have real lives. There's a variety of other models we're developing in New York besides Peer Bridger. We have peer crisis diversion, the warm lines, and respite houses. We have the peer bridging that I mentioned, not only at state hospitals and Medicaid hospitals, but nursing homes, adult care facilities, homeless shelters, jails, and prisons. We have the wellness coaches. We have life coaches. We have peer-supported housing. We're generating a variety of peer services. We don't have enough peer services or peer-run agencies to manage all of the demand that's going to be there. One of the tricks about that is then probably traditional agencies will hire sort of peers who are credentialed, but we worry won't use them in the right way and won't supervise them correctly. So this is where the peer approach that's required sort of cuts both ways. We don't want to be co-opted. We want to do the things that peer support really came to do, very much about relationship and working with the person, starting where the person is. You know, we don't start with medication. We start with housing, if that's what the person needs. We help people get emergency housing. If they're poor, we help folks get back into that. If they're hungry, we start with where the person is. That's really critical. I know you're in California and in the nation, we're arguing about forced outpatient treatment. And you know what? You can engage people a lot better if you start where they are. You go to where they are and you offer them what they want. Next thing you know, you have a relationship. And even with the most needy or the person that has the most risk and reluctance, we're really finding a lot of results with that. So New York is a Medicaid junkie. You may have read about us in the papers, and your Darrell Issa kicks our ass regularly about this. I don't know how you like him. He's not big in New York. Not big here either. Oh, well, then, better here than there. But we deserve to be under the microscope. We have medicated everything in sight, and we haven't, we've spent a lot of money in the wrong places without the right outcomes. So New York went to the feds and said, mea culpa, and then they said, we want more money. But we will save you $16 billion over 5 years, but we need to preload this, so we need $8 billion. And we're getting it. And what's happening with it is we're spending it in particular ways. The most significant way is DSRIP. So in our state, it's going to be hospital-generated sort of networks, regionally based, high performance, and meant to reduce Medicaid utilization by 20%. So it's a high bar. And I was just on phone calls today where we're really working to link mental health providers with hospitals. There's a lot of, these are forced marriages, and they're moving very quickly. And again, it's very stressful, but for somebody who's been waiting for recovery a long time, roll the dice, I say. Let's really move this along. If you have hospital-based networks that are buying peer services and behavioral health services and doing it integrated way with a high bar, that's good for people, and it's potentially good for behavioral health. We also are front-loading by $1 billion the eye services. So these are the recovery services I mentioned before. These are the partners in the DSRIP program. I'd love to hear about yours. So we're spending a lot of money. Deinstitutionalization, we've often been criticized by reducing money from hospitals but not putting it in the community. But we're front-loading 120, besides the district monies that are coming, our Medicaid director has put $120 million in the budget, and we're closing state hospitals, which you don't have as much of, and we're reinvesting $25 million there. So we're really excited about it. It's chaotic. There's some risk involved, but it's ultimately better for people and hopefully for the state of New York. Thank you.
Thank you, Harvey.
Again, very interesting presentation. Do you pay your care managers to be on call 24/7 to establish the relationship, or do you have a rotational so that someone in the health home may have to go to the hospital at 3 a.m.? How do you arrange that, please?
Well, I think it's to the care managers, and I think it's part of the job. Yeah.
I have a question. There's a rich, diverse group of people in the room, including folks who provide mental health services and folks who provide primary care. And are the folks that do that here the kind of people that are running health homes in New York or not?
Health homes are run by, to some degree, there's hospitals that are running them. There are provider networks that are also running them. I would say it's more behavioral health providers, pretty much in New York, than it is medical.
So there are
There are new organizations. You know, there's a lot of mergers and consolidations, so there's a lot of networks that have formed in order to run these things.
And could you make a comment or two about the behavioral health providers and say a little bit more about how successful they're being at, you showed some slides, but make some more general statements.
I would just say that if you recognize that people with behavioral health conditions are in the crosshairs of all this overutilization and poor outcomes, behavioral health providers are increasingly being seen as the link, as the glue, as the engager to this. There's no point developing a better system if people won't go to it. So I think behavioral health is proving itself to be the outreacher, the engager, the diverter, the transition agent, and I think that's very valuable. And I think the medical world is seeing they're on the hook, the health plan's seeing they're on the hook, and they have to work with our people and ourselves, and they realize increasingly how they need us to do that. On the behavioral health side, though, is a big, we've sat in our offices and done fee-for-service and said this is the best we can do because this is the best that they can do. That's not acceptable anymore. It's a wonderful thing. We can have all this great talk about recovery, but when the money dictates what people do, and when providers have to help in networks folks recover, then that's what they're going to do.
I actually have a comment and then a question for Gale. Because
there you are.
I'm here, Gale. So one comment is that we're talking about integrated care here, and most people that know me know that I'm really pushing for that. Behavioral health is great. Let's not forget to give the same amount of attention to substance use disorder, because we always find that gets short shrift. It's 80-20%, like we're an afterthought. But Gale, I had the pleasure of working with Gale and overlapping in the San Mateo system, and we have a county hospital system where everyone touts that Kaiser had this whole integrated care, where, Gale, that the basic integrated care where you had nothing and you had to make something out of nothing was working with those county systems. As we listen to the presenters and as we listen to the models that they have presented, I would be interested in your feedback, and I think the group would really benefit from years of experience in seeing how that was the model for a long time with county hospitals of trying to get that integration to occur, and what you've seen, given your different roles, as we're here today, to bringing in that public health into the commercial side.
Well, I'm going to respectfully not give you much of an answer, because I think what's important is we've got folks in this room who have that whole range of experience, including on-the-ground integration work from the substance use perspective, which is good. We really went after having folks here who've got some experience with substance use disorder systems, as well as FQHCs, et cetera. So I do think, I guess one of the things I want to ask both of our speakers is, because when I think about things that have been tried in California, including, some of the integration work that I've done when I was a director and with others, the challenge is always, how do you keep on learning? How do you keep on testing the changes you put out an array of immense changes for New York. So how do you keep the system improving, and how do you know you're getting to where you're trying to go? Both of you spoke about outcomes, and that's one way, but I'm just wondering in general. I know that Christina, you've done some work in that arena. So I think for all of us, we want to get models, we want to get exciting innovations out on the table, but then it's how do you fit them to your local system, and how do you sustain them? So I'm tossing the ball to Christina.
Well, we talk about this a lot. One thing is we're trying to change, this is more just rhetorical to say this, but we're trying to change the paradigm shift at our clinic of always saying, like, well, we're almost there, because because things change, the environment changes, and it seems the needs of our patients and our reimbursement model is changing so fast, as our first speaker said, that we never quite get there because something sort of new comes along that we need to address or modify how we're delivering our care to fit. So we sort of feel like we're always a little bit in pilot stage. That being said, we went to Care Oregon after having underwritten the presence of the social workers in our clinic for 3 years, and they saw the outcomes we were having in terms of patient satisfaction, in terms of provider productivity, provider satisfaction, some of our actual health indices changing, and us saying we think this is in part because of our behavioral health specialists. And we said, we need you to pay us per member per month, $6 per member per month, to keep these behavioral health specialists here. And they said, sure. It was just like that. And I think part of that was the relationship we've developed with the payer, and really being willing to go to them and negotiate. And so I think for us, the sustainability has come from the relationships with the payers.
So that actually was one of my questions. So thank you. I want to turn it back to the audience. Great. Okay, let's go.
My question is around the peer providers. Are they able to bill for their services in your system? And the second question is around peer providers providing substance use services. How do you train them and bill them, have them bill as well? That's my question.
So let me take the second one first. I think we're just developing a mental health credential in New York for mental health peers. And there also is already a certification for addiction peers, but they're slowly being merged. And we're just learning about each other. We're learning about how different the addiction peer system is than the mental health. The mental health system peer programs are, even though recovery and peer support long preceded mental health in the addiction community, professional peers, there's not as many as there is in mental health. Peer-run agencies, many more in New York. So I think we're just learning about each other and how we're going to work together. And there's an addiction recovery coach credential. The mental health one is coming. An addiction agency that already delivers a credential is going to take over the mental health credential. So it's a process where I think we're going to learn from each other, and then the funding and the credentials, people are going to be looking for a blended sort of coach. And the first question was, how are they going to get reimbursed? It depends where they're, right now, like I mentioned earlier, NIAPRS, which does a lot of things, including field tests, these new peer innovations. We have these quarterly grants from the health plans. And the money comes to us, and the employees are NIAPRS employees. We supervise and pay them. We're paying about $40,000 a year for trained peer professionals. But that's preliminary. We haven't actually gone to full capitation. And I would think that for the peer-run agencies, they're going to have to learn to rate set and design, market, and rate set, and get paid as one of the providers in the network. So that's coming. But for now, the flexibility of having these quarterly grants has been great for us because we are able to do startup and wraparound and a lot of different things that normally you're not sure. The other part of it is that engagement is the key to this work, and in many instances, reimbursement doesn't pay for months of engagement, and that's going to be critical, I think, to this working well. So we have the flexibility in our grant program to do what's necessary to engage. But the other concern we have is that many of the peers will be embedded in traditional settings, and we really worry about whether they'll get to do what they're supposed to do, or they'll just be an employee of a clinic, and they'll be part of the clinic rate, you know, that gets billed. So we're very concerned about that.
Mr. Rosenthal, right here.
Oh, gotcha.
Hi. Thank you for your presentation, and forgive me, maybe I missed part of your presentation, but I know that some health plan in New York contract with managed behavioral health organizations. So have you guys worked out the contractual and the financial agreement with those kind of setting where you have a health plan and then you have it delegated to an MBHO?
Well, ironically, you would think that these big health plans who don't have a lot of experience working with people with more serious mental health needs would want to subcontract with a BHO, but I think the lure of the money is too strong. And so they're overnight. Some of these health plans have not had experience with people with more serious needs, but they're wanting to do it by themselves without subcontracting with a BHO. Some of them will, but it's not clear yet. We're just in the process of the plans being selected. Well, we have the subcontract. We have a contract with Optum Health, a BHO, as well. So Optum has been sort of, you know, moving into peer services for a while. But again, they've had grant-funded arrangements with groups like ours. Now they're moving to quarterly, you know, 15-minute billing. But if I understand your question, do peer programs contract with? Are there MBHOs and health plans that are contracting with peer services? In pilot fashions like ours, we're in both, and we do it to kind of to pilot it, but you know, it's just coming to fruition. Once the HARP comes up and the expectations are that there should be a lot of that going on. Right now, there's not as much in New York.
Christina had a comment too.
Sorry to jump in and backtrack a moment, but I did want to, we have, I think, a process of always thinking that the best way to integrate mental health services in the primary care setting is to bring the mental health providers into the clinic. And I agree with that. We've had such success with, as I mentioned, bringing the psychiatric nurse practitioner in, bringing the social workers, behavioral health students. That's been very effective for us. But we've also we've kind of turned the coin around and have started dropping medical health providers into mental health settings. So my clinic opened up it's not an urgent walk-in, it is a primary care walk-in clinic at Cascadia Mental Health, which is a huge intensive mental health outpatient treatment center about 5 blocks from our clinic. So we have family nurse practitioners staffing that clinic. It is not just urgent care. It can be urgent care, but it essentially is a way for people who would never otherwise have been able to really cope with our very regimented, you have an appointment at 10:40 with Dr. Milano. They can just walk in whenever the clinic is open, and that has worked very, very well for Cascadia to know that they have this medical health service integrated and under the roof of the mental health. Similarly, we're providing maternity care at one of the methadone treatment centers. It's the ambulatory methadone treatment center. It's not inpatient. But again, because we're realizing some of the difficulties or the way that our clinic environment doesn't work for certain sort of settings or circumstances or patients, that it's better if we go to them. So I just wanted to highlight that as the other side.
Oh, I just kind of wanted to respond to what the gentleman in blue, what you had said, is that in Santa Cruz County, California, we have a peer support organization called MHCAN, and we actually are contracted with one of the local, with Telecare, which is a big corporation that provides healthcare services, and we provide peer support services with them. So that is already happening in California. We get paid, actually, our full-time peer support worker earns $40,000 a year, exactly what they are in New York. So, but we get paid through contract, a yearly contract.
Okay, let me open it up to other questions, comments.
May I?
Okay, yes, thank
Harvey,
you.
we've been here in California. We've been kicking Laura's Law around for a decade or more.
So I understand.
And I'm curious what your take is on how you feel, from what you said, the peer support concept really offers a viable alternative to the assisted outpatient treatment.
Yeah, and I don't want to over-leverage peer support because I think sometimes we do that and act like, we have all the answers, and we do not. It's really important to say that, but we don't have to. We're only one element of a continuum that needs to be available. I just want to say that you're going to read again and again that Kendra's Law research proves that forced outpatient treatment works. It does not. It has not really done apples to apples around people getting the same array of services and everyone in and proving that it's the court order, not the enhanced accountable services, that makes a difference. So we had 7,000 voluntary sort of engagements, 8,000 court orders, and they never compared them, even though we got that in statute that they had to. So I just need to editorialize about that. But I do think that, to give you an example of the fellow that I was talking about earlier, we have something very important to offer, and even in the Murphy Law that the one you're maybe hearing about, the bill, where I think we've been working to put in there, he originally had outpatient commitment as a requirement of getting the block grant, and I think now they're moving to outreach and engagement, and assisted outpatient may be one of the strategies. So, again, I think we haven't seen peer support at its best, but and really engaged as well as that. I also think that we don't respond to families well, truth be told, and that's a big piece of where outpatient commitment gets called in, because families really do see people in great suffering, and we've not responded to them, either peers or the system. So that's another piece that has to be addressed.
Thank you. One of the reasons, for those of you who can't see me, one of the reasons I asked, Harvey was going to talk about the role of people in recovery and really systems change, and Christina also. And the reason it seemed important to do some highlighting of that is that in California, we're really kind of on the cusp of sorting through how in the heck do we provide more intensive support, more intensive care coordination, whatever the term we use, for folks with complicated, complex problems. And who's the workforce who can support that? And so the role of peers, especially as we look at workforce capacity, seemed an important one to push out. And it's one that's actually emerged from the learning collaboratives that we've been leading as well. So with that editorializing, I just want to move it on to another kind of question. Katera?
Yes. Thank you guys for your presentation. I am curious about the customer satisfaction of services. And in California, we have, if you receive federal grants or block grants, you have to use the MISHIP. And I'm not, what I've heard is that the data collection is not very consistent, so it's not reliable, the information we're hearing. So here we have, as a state, and then so every kind of organization does it differently, their own way, but we're not able to, as a state, look at one consistent tool that shows how our consumers, the people we're serving, the customers, are they satisfied with the services that we're providing them? And then that information is not coming back to us to help us improve the services. Now, we have a lot of, I'm not saying that we don't look at data and outcomes, we do, but we don't have anything consistent. And that is something of an issue in our state. I'd like to hear what New York and Oregon is doing. And, in my opinion around this topic, the question prior, is that if I am forced into treatment, I don't think I'm going to be satisfied, and maybe that's why you don't want to know how I feel about it, but I know consumers across the state and across the nation are not happy with involuntary outpatient commitment with Laura's Law in our state. So the AAA asks for customer satisfaction. We want to know how people, are they satisfied with the services? And so this is really important in achieving that. So I'd like to know what you guys
I would just say two things to that. One of them is we don't measure consumer satisfaction in New York. We've not really focused on that. I think it's very much focused on keeping people out of hospital emergency rooms, not necessarily what people are doing when they're not out of hospital emergency rooms. So we're not there yet. We may get there. I will say the other thing, there is research, and this is sort of troubling to explain, where people are in New York who are part of the Kendra's Law cohort have reported that they're satisfied with law. But it's hard to know, if you weren't on an order, I don't think you would say you're not satisfied. So it's hard to know how credible that is.
Hi, did you go?
Oh, I was just going to respond. So we're in a different, because we're in a medical setting or physical health setting, we're required to use the Press-Ganey model, which is what all of the health systems are using for patient satisfaction. And so unfortunately, it doesn't really capture the sort of spirit of the mental health services that we're providing, because it's very focused on the experience of the patient and seeing the medical provider they saw that day. We have had, for the particular project I was telling you about, an external group called CORE doing patient qualitative interviews. And as you can imagine, given what I described, patients love it. They love the idea of having someone working with them so closely and engaged with them and supporting them. So for those unique interventions, it's very favorable. But Press-Ganey has been incredibly difficult to really rely on with our population. Our scores seem horribly low in comparison to the nation, which they are, and that's been really challenging and frustrating as a clinic when we're all obviously working as hard as we can.
Dr. Milano, I wanted to ask you a question to follow up on your example of the other side of the coin.
Oh, sure.
So we've tried to do things like that in San Diego, and where we've fallen short or where we've had a challenge is being able to get enough clients or patients in to make it financially viable for, say, an FQHC who might decide to outstation somebody like that. So what, in your example, how was that funded or financed and made to work?
So I'll just talk a little bit about the walk-in primary care clinic. So it's an open clinic to everyone in the community, so we don't advertise it specifically to one group, like if you're Medicaid or if you're uninsured. It's open to everyone, including an OHSU employee whose kid has a cold and needs to be seen right away. So we are seeing all comers, and we bill as we would in whatever the patient's paying status is. If they're uninsured, they're free. And we're able to bill the state. Essentially, the state said, you're fine having that walk-in primary care, but that will not qualify as a patient-centered primary care home, and you won't get the PCPCH payments. And we said, absolutely, we don't want those payments. We aren't doing any care management. We aren't doing any population outreach. But if somebody shows up and wants a PAP, they can get that. And so we get a payment we can just bill the state as we would if it's a Medicaid patient, and we get fee-for-service for that. So thus far, it has worked. It hasn't been without a lot of we promote the service within the context of the environment that we're in, and we also have to be cautious about trying to encourage others to come there who might say, why would I go to a clinic at a mental health place for my kid's cold? So it's a fine balance.
So you guys both talked about housing is an issue, so housing is treatment, and you just touched on it on one that you're not doing very well with that segment, and you said that you're doing some stuff. Can you give more details of what you are doing as housing as treatment?
Again, our Medicaid director is buying housing. It's pretty amazing, I think, with the state share of Medicaid savings. So we're putting up a lot more housing. And I think what we'll see sort of leveraged is the housing first model. Are you familiar with that? So that's a great homelessness, prevention model. So I think that's what I can tell you is where we're focusing right now. We don't have a great record yet on averting homelessness either, but I think, again, if homeless folks are part of the HARP and the plan is expected to reach out, engage, and stabilize, I think you're going to see even plans willing to put up some money for like emergency housing at least.
My behavioral health providers would never ever talk to me again if I did not mention to you that the word of the day or the phrase of the day in Oregon among all behaviorists is understanding and learning about trauma-informed care. And I will leave you with that. I see lots of nodding heads. But that is really in the last year taken off as the way to go.